everyone. I'm very pleased today to be joined by Susie Davey and Dr. Laura Redman, and we're going to spend a little bit of time talking about lymphedema, conservative measures which can be explored, and then also surgical measures which are now available in South Africa. So we're hoping to give you a bit of a feel for all of those things. So I'm joined by Dr. Laura Redman. She's a general and vascular surgeon with an interest in lymphatic and venous conditions and has devoted her practice to this speciality. She's trained abroad in multiple units in both venous and lymphatic conditions in order to create a center of excellence in South Africa. She's president of the South African Lymphatic and Venous Society, and she's also on the advisory board for the Lymphatic Association of South Africa. And then I've got Susie Davey with us as well. She's an occupational therapist and specialist and expert in the field of lymphedema management. She founded the first multidisciplinary lymphedema therapy clinic in Hallandale Beach in the US and has been involved in clinical research worldwide. After moving to South Africa in 2012, she recognized the need for more awareness about lymphedema conditions and established Lymph Africa. Her mission is to educate all healthcare professionals in South Africa to recognize, correctly identify and diagnose lymphedema conditions. And then my name is Simone Blankenberg. My journey with lymphedema started about 8 years ago. Initially, I was diagnosed at the age of 23 with a malignant melanoma on my right shin. And I had surgery and it was very quickly dealt with. And I really didn't think anything more about it for 6 years. And then the cancer came back much more aggressively when I was 29 in the lymphs in my right groin. I had a full lymph block done. I had 6 weeks of radiation. And right at the outset of the radiation, my oncologist and my plastic surgeon both warned me about this thing called lymphedema that I may experience, which is essentially the swelling in the limb due to the cancer treatment and the removal of the lymph glands, as well as the radiation damage which was caused in the area. So I was very proactive in terms of seeking help with my lymphedema really straight after my radiation. And for the first 18 months, my lymphedema was very under control. I went for manual lymph drainage and bandaging. I wore compression. And I really continued a normal life, and nobody would even really have known that I had lymphedema. And then about 18 months after that, I had my first child and I had a C-section. And this is really when my lymphedema got really, really bad, literally overnight. So what we hadn't realized was that the lymph fluid had learned to reroute itself through my pelvis or through my pelvic area. And when I had my C-section, the new roots were essentially damaged, and suddenly my lymphatic fluid had nowhere to go. And I went from my lymphedema being completely under control to being completely out of control, literally within 2 or 3 weeks. From that point, which is now seven years ago, I have done everything possible to try and control my lymphedema. So I've explored all conservative measures. I have always been in custom compression. I have had manual lymph drainage and bandaging twice a week at least for the last 7 years. I have controlled my weight. I have always ensured that I eat well. I have done elimination diets. I exercise a lot and very consistently. And nothing was able to control my lymphedema. And really my right leg just continued to get bigger and bigger and bigger, no matter what I did. And so I started then looking at what other measures were available to me to try and assist with my lymphedema. And this was probably, well, initially when I started looking at this was 5 years ago. And at the time there was no surgical intervention available in South Africa. And then about 2.5 years ago, the first surgical intervention that became available in South Africa was a vascularized lymph node transplant, which I had done. This helped my leg in that it improved the quality of my leg. The leg was much less angry, much less red, and was much softer, but unfortunately didn't take down the bulk of the leg. So I then started looking at other kinds of surgical interventions that we could look at. And there was a surgical intervention which was available in Sweden, which is a debulking operation, which Dr. Broughton had been doing in Sweden for over 30 years. But it wasn't available in South Africa at all. And I realized that this was really what was going to need to be required to do to remove the bulk in my leg. So I started talking to Laura and to Susie, and we started down a path of trying to bring the surgery to South Africa. And so this is probably a good place for me to hand over to Laura for her to explain why the bulk in my leg needed this kind of debulking surgery, and what she's learned about lymphedema and about the process with Dr. Broughton. So thank you, Laura, for joining us today.
Okay, pleasure. Thanks so much, Simone. Okay, so the entire lymphatic system and lymphedema has been a very poorly understood aspect of medicine, and currently there's been researched more and more is being understood. So lymph itself is a part of the circulation and has a role in fluid drainage from the limbs and the body back into the blood. It also has a role in lipid transport and in immune surveillance, including the spread of cancer. And one can't actually survive without the lymphatic system. Lymphedema itself is a condition that occurs from disruption of the lymphatics in a limb. And this can be a genetic condition which occurs primarily at any time during one's life, or more commonly, secondary lymphedema, which is related to infection or radiation, or importantly, as in Simone's case, cancer-related surgery. These cancer-related surgeries are ones that require resection of lymph nodes in the axilla or the groin, and this leads to destruction of lymphatic vessels, so lymph cannot drain out of the leg or the arm, which leads to swelling. And if this is not managed properly, it can lead to skin damage, pigmentation, and even wounds. What was never understood about lymphedema, and what's never actually initially accepted, is that when lymph fluid cannot move, it turns into fat cells. And this was the first area that Dr. Broughton actually pioneered and investigated. And he did this through imaging patients with CTs and MRI scans. More research has subsequently been done, and currently scientists are looking for what's called an adipogenic factor in lymph that actually causes these fat cells to develop. And treatment for lymphedema then has been primarily conservative, meaning it aims to try and control the limb size and prevent skin deterioration or limb deterioration. This is done mainly by decongestive therapy in terms of compression stockings and bandaging. And then the surgeries that have been described initially were large resectional surgeries, meaning all the tissue is removed to the muscle and skin is grafted over this, which is quite barbaric, and it results in very unsightly limbs with lots of complications. So this isn't typically done anymore. However, microsurgical techniques, which include lymph node transfers or lymphaticovenous anastomoses, can be done to try and drain the limb. They may help maintain the limb condition, but they can't reverse the fat cells that have developed. And they do have a potential to block as well. So they're helpful only up until a point. And this is where Dr. Broughton came in again and then pioneered liposuction. And the thinking behind this was to basically remove all the adipose tissue in the limb, and which is notably uncontrollable by the patient, and reset the limb to the volume that it should be. And thereafter, compression plays a vital role in maintaining the limb size to an equal size, such as the other limb. So Dr. Broughton has really been inspirational in driving understanding what is happening in the leg, and then what can be done effectively to improve the patient's quality of life.
That's really insightful. Thanks, Laura. I know Dr. Broughton does speak quite a lot about surgical intervention not being the first thing that you should explore, and having the need to have explored all of the conservative measures available to you first before getting to the point where you look at these surgical interventions. So Susie, perhaps you could touch on for us the conservative measures that people should consider before looking at this sort of treatment.
Absolutely. Thank you so much, Simone, for having me. So the conservative measures, it would be something called CDT, which is short for either complete or combined decongestive therapy. And this is the gold standard worldwide of the treatment of choice for conservative measures for helping patients with any type of edema, or specifically lymphedema. And what it involves is a treatment of manual lymph drainage, which is a very light skin treatment or massage that helps reroute the fluid from the edematous area through stimulating healthy lymphatic areas, healthy lymph node areas, and then eventually this fluid being drained out. And then after the manual lymph drainage session, a therapist would then apply short stretch compression bandaging. And this treatment could last or should, depending on how invasive the edema is and how prolonged they've had the lymphedema, how much fibrosis, how much skin changes they've had. The treatment can be anywhere from 2 to 5 days a week, and could be anywhere from 2 weeks to 6 weeks or even 8 weeks long for an intensive phase of lymphedema therapy. But to really, to give it a shot, at least 4 weeks of treatment, I think, is required in my own personal experience with the years that I've been doing this work. And then after they've had the bandages applied, patients, of course, are encouraged to do remedial exercises and movement and walking and just really moving around to help get the limb pumping with the lymphatic system moving and really helping to get the edema out of the limb with the bandages in place. And then, of course, the last component of CDT is skincare, ensuring that the skin integrity is intact, that the skin is being moisturized properly with the right pH balanced lotions or ointments or heavy creams, depending on the skin integrity. And of course, to prevent any type of infections, such as a cellulitis infection. And to really encourage patients to continue with this once they're done with therapy, that they should continue with their moisturizing of the limb and inspection of the limb to ensure that they're not having any types of infections. And then the other aspects of conservative therapy, which are really helpful, are there's devices, a lot of different types of devices that can help a patient, such as a pneumatic compression device, which would be a device, a unit that is a patient can place their arm or their leg into, and it pumps at a sequential gradient pressure. And again, this should be specifically types of pumps that are specifically made for lymphedema with a setting for lymphatics, as opposed to just a venous pump where it's pumping. Venous pumps usually pump only distally to proximal from the toes up, but a lymphatic pump would be something that would help clear and decongest the proximal area, and also not pump it too high of a compression. Some other things are items such as kinesio tape or elastic taping, very helpful with reducing edema, softening fibrosis, reducing pain. It's very effective. And then I think one of the most important things that is often not touched upon in as much detail as probably should is patients' nutrition, and their diet is a vital portion of our therapy, and ensuring that patients are drinking enough water, again, making sure that they are allowed to drink water with no kidney issues, but then also how much sodium and preservatives that they actually have in their diet. Sometimes foods, even if they don't taste salty, could be high in sodium, and this is additionally making them retain fluid in their body. So this is a big important component, and trying to focus and having them eat more healthy, natural foods as opposed to processed foods. Very important. And again, I can't stress enough how important exercise is. So those are all of the main components that we review in conservative therapy. And then finally would be the compression garments, which I can talk about at the end. The compression garments are vital.
Thanks for that, Susie.
Mm-hmm.
So Laura, both you and Susie went over to Sweden to be trained by Dr. Brawson last year. Perhaps you can just share with us your experience, and then obviously bringing this technique back to South Africa, the many hurdles we had to get over before you could perform the surgery, and then the performance of the first surgery of this kind in Africa, and what your experience was.
Okay, thanks, Simone. Yeah, so firstly, Dr. Brawson will only train in teams. He won't train individuals. So the first sort of key point is that it is a multidisciplinary team approach, and that's why both Susie and I went across for training. And the reason for this, though, is that the patient needs to be fully prepared for the surgery pre-op to make it successful, and then be prepared for post-op care and lifelong compression. So in fact, the actual surgical part is quite a minor part of the entire life of the lymphedema patient. So pre-operatively, the patient has to be compliant with the compression and have the desired results, is that there's no fluid in the leg, but only fat tissue. And then Susie mentioned about looking for that edema and removing that. And so what we only want to be removing in surgery is fat tissue. If there is any fluid present, then more intense lymph drainage or decongestion needs to be done. And then the patient must be compliant with that and with the garments they'll need to wear post-operatively, which are during the day and at night for the rest of their lives. So this is the thing that will ensure success and that there won't be reaccumulation of lymph in the fat tissue. Dr. Brawson then also created a program to actually measure lymph volume, and we use that as well. So we know how much to remove during surgery so that it matches the other limb. And we use the same program post-operatively to assess the results. Patients also need to be of a reasonable weight, and we use a BMI of 30 or less. In terms of the actual surgery itself, the operation is performed under general anesthetic. We give antibiotic and anticoagulant prophylaxis. And then essentially we make a whole lot of small cuts in the limb and use a power-assisted liposuction machine to remove the fat. This is done from the hand towards the from the foot towards the groin, or the hand towards the armpit, and we go around the entire leg. Now, there are many power-assisted liposuction machines available, but Dr. Brawson recommends a specific one which he compared to others and believes that is preferential for this type of surgery. And he actually designed some cannulas for this machine. And importantly, though, he's very passionate. There was no financial benefit to himself, so he's very objective in terms of what he teaches. This was one of the hurdles because we didn't have the machine in South Africa and we couldn't get it. But we have managed to do it. We got it from Belgium. It just needs to go back there for servicing. So it's an ongoing, I suppose, hurdle in a way, but definitely worth it. And then after the surgery is done, the compression garments that are custom made and have been measured are put on in theatre, and a dressing change is done with the therapist on day 2 and day 4 after the surgery. It is important to inform patients though that it's intense surgery and the entire limb is operated on. So there is a significant amount of post-operative swelling. This can take up to a year to normalize in lower limb patients and 6 months in arm patients. Correct compression will help achieve these quicker. It's also important for the patient to realize that the wrist and ankle, elbow and knee won't return to normal shape because you can't get compression around those areas circumferentially. The other important point Dr. Brawson mentioned was that you can't often get fat tissue out of the hand or the foot because there's quite a lot of fibrous tissue there. We are happy to try. We did in Simone and she had some relief and reduction in the foot, so you can always try it. But it's important to be aware it might not work. And then the last thing is that the patient just needs to continue with their compression and keep with their appointments with their lymphedema therapist. Because the compression sizes will change, and to get to your goals and throughout life, the weight's going to change. So it really needs to be maintained in order to get those excellent results.
Thanks for that, Laura. Susie, as Laura's mentioned, it's the compression side of things is really very important for the success of this operation. And this is really your area of expertise. Perhaps you can share with us what is required from this perspective.
Yeah, so the compression that he has been traditionally using is, it was really interesting to learn and to go and to witness and to experience in Sweden, because always therapists are taught never let patients sleep in garments, you know, and that I think is something that every therapist will tell you if you ask them if a patient is allowed to sleep in compression garments. And here Dr. Burson's, Dr. Burson's procedure, he is applying, like in your case, we apply a compression class. His recommendation is to apply a compression class 3. And then also for daytime, we're applying a compression class 2, thigh high over your limb, one-legged panty, and then a thigh high over in flat knit, not circular knit. And then for nighttime, you're sleeping in a compression class 3, which again, is not usually something that you hear people recommending. So this was a big eye-opener for me. And then also while I was in Sweden, we came across patients who had been wearing compression class 4 and then a compression class 3 over. So there was varying degrees of how much compression people were wearing, the different materials, of course, always flat knit, but the importance, you know, can't be overstated, that a patient has to embrace and understand that the compression has to be worn during the day and at night, lifelong. And if a compression, if a patient isn't able to tolerate the compression garments, this will eventually lead to the reaccumulation of fluid. Now, in your case, Simone, we did find a happy balance. And if there are times or days where a patient is really struggling, then, you know, as long as they can work or have been taught to do their own self-compression bandaging at a high enough level of compression. And there's great devices, you know, wonderful devices out on the market with Velcro wraps and foam paddings. But the key is the containment of the limb. And I think you were able to find that balance, Simone. But for the most part, and you can share your experience, that you are able to wear 2 compression garments during the day, and you do sleep in a compression garment at night, I believe. And you can share if sometimes you do wear something else, but it's super important.
Thanks for that, Susie. So yes, I landed up having this debulking operation on the 6th of March of 2020, just before heavy lockdown in South Africa, thank goodness. So we got it done just in time. And I must say there was a real huge effort to get to the day itself. As you can hear, there was training that happened before, people flying all over the world. We had to get machines, we had to motivate to medical aids, we had to fight with medical aids. So this was certainly not an easy process, but, and I must admit, I was worried that the operation wouldn't work because, you know, I was putting so much hope in this and we put so much work behind it, and then I was terrified it wouldn't work. And we had the op, and I woke up and I could immediately, you know, the op was about 6.5 hours, and I woke up and there was an immediate difference. Firstly, I couldn't believe, so before you have the operation, you have your stocking measured, and it's based on the measurement of your normal leg, in my case, the left leg. And they base that, they try to get your right leg down to what the size of your left leg. And I didn't believe in a million years that they would ever be able to get the stocking onto my leg in theatre. And I woke up and they had managed to get it on, which was just amazing. And I had this skinny little leg, which I hadn't seen it looking like that for 7.5 years. I definitely did have pain, so it's not a pain-free op, but I had quite a lot of neural pain, which I think maybe is unusual. And once we managed to get that under control with medication and then with a bit of physio, it was actually got much better. As Laura mentions, there definitely is bruising and swelling, but nothing more than I think you would imagine given the kind of operation that this is. I mean, it is a big op in terms of what they have to do and kind of how they have to treat your leg. So there is pain, but it's not unbearable at all. And I must say my life has been completely turned around. So in surgery, I think if I remember correctly, we managed to get out about 4.5 kilograms worth of adipose tissue, which is just quite unbelievable. So the volume of my leg has now gone from kind of 15,000 down to about 11,200 mils. My normal leg is 11,100 or 11,000. So it's only about 200 mils bigger than the normal leg, which is just quite amazing. And the improvements in every single area of my life is quite dramatic. So from my mental state of being in terms of how I feel about myself to my physical state, I as I mentioned, I exercise a lot. I run a lot, and I was continuously in pain. My hip pain was becoming more and more unbearable because of the impact that an additional 5.5 kilograms on one leg was having on my joints. my ability to be able to get up and down off the floor, and just my general mobility was dramatically impaired. I couldn't wear normal pants, I couldn't wear normal shoes, I couldn't wear closed shoes. And so I spent every single winter freezing cold because I just couldn't get warm, because I couldn't wear pants and I couldn't wear closed shoes. And so that's been especially this cold winter we've had in Cape Town, that's really made such a big difference to me. And then I can now exercise so much more easily. Running is, I go for a 10K run and I don't even blink. I don't even have to think about it anymore. Whereas before it was a real mental challenge, and it was all about just mentally pushing through, doing what I needed to do. As Susie mentioned, I am in compression 24/7. So I was always in compression. So I've been in compression before, but I never used to sleep in compression. And I had gotten up to being in a compression class 4 pre the op. So the change has been that I'm now in a one-legged panty class 4 flat knit, with another one-legged panty class 3 over that. So I'm essentially in class 7 compression. That's bearable for me. It's not comfortable, but it's absolutely is bearable. And then what I do at night is I take the class 4 off and I sleep just in a class 3. That's definitely been the biggest thing to get used to, and the most difficult thing to get used to. So I found it in the beginning very hard to sleep in the compression. And so I've got a number of different ways that I kind of got myself used to it. I've got a number of different Velcro garments, but I'm now back in sleeping either in a class 3 or class 4, because I just do find that that is the way that I get the best containment. And I'm terrified that the fluid builds up in my leg again. And so I'm just wanting to do everything possible to make sure that this operation continues to be a success. So it's been a long journey to get here, but it truly has been absolutely life-changing. And I'm just so excited that this sort of surgery is now available here in South Africa to help so many other people. And I can only say, if you're a candidate, it is just so worth it. So I'm forever indebted to both Susie and Laura for everything that they have done to change my life, and to hopefully change the lives of many patients who will come and see them. They have had endless energy. I have consulted them any time of the day or night, weekends, week time, and they are just always available, and operate with the utmost professionalism. So thank you so much for all that you did for me to get me to this point. It has been wonderful. So thank you very much to the both of you.